This episode is brought to you by Contact.io. Contact.io delivers outcomes, not just boxed hardware. Unlike legacy RTLS software, their AI-powered RTLS platform supports better healthcare operations, immediate response for staff safety, 75% fewer equipment rentals, and 20% shorter lengths of stay. With a pricing model designed to deliver ROI in months, not years, Contact.io makes it easy to scale quickly and ensure operational excellence. Keep your staff safe, productive, and equipped to provide exceptional care at the right time, every time. Join leading health systems already transforming care with Contact.io. Learn more at thisweekhealth.com/contact-io. That's KONTAKT-IO.
Today on Newsday.
There's a lot of AI governance conversations right now, right? And if you delete the word AI, you put in a different word, cloud, IoT, it's kind of the exact same conversation we've been having, right? Like 3 years ago, 5 years ago, it hasn't really changed.
My name is Bill Russell. I'm a former CIO for a 16-hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Newsday discusses the breaking news in healthcare with industry experts. Now, let's jump right in. All right, it's Newsday, and today we are joined by Philipp von Gilsa, CEO, Contact.io. Philipp, welcome back to the show.
Hi, Bill. Thank you so much for having me.
Love the fact that you're recording from your office and you have your whiteboard behind us. So if people are listening to this on the podcast itself, if you want to see all the things that Philipp is working on, you're going to have to tune into the video to see all the stuff behind him on the whiteboard.
Yeah, but like I've just told you as part of the heads up, I think I've asked the team to make sure that nobody can actually read my handwriting, and they confirmed.
There is nothing readable on that entire board.
Yeah, so, except I think IPA, which is not standing for beer, but it's an internal acronym for an extremely important strategy we're working on that is going to cure a lot of things in healthcare. But that's not the topic for today.
We have 3 headwinds. Let's call them headwinds that are facing healthcare leaders, health IT leaders across the board. I want to start with the America's hospital bed shortage. This is from the Wall Street Journal. Sandeep, who is actually a physician from, I think, one of the larger
Northwell. He's from Northwell. And by the way, I think we're going to talk about his article. I've reached out to him after the article, and we're going to speak next week. And I think he wrote a couple of books, and I encourage you to maybe invite him as well, because this is one of the sort of articles that I didn't discover. It's like my wife on a Saturday saying, look, what's in the Wall Street Journal? Because it was prominently sort of on the second page. And I thought, great, it's one of these themes that are covering and touching everyone. So worthwhile discussing and chatting about it here.
All right, so let me give people, so American hospital bed shortage is about to become a crisis. And let me give you the synopsis here. Most compelling aspect is 85% occupancy threshold warning that hospitals may cease to function properly once they hit this critical point. And the U.S. could reach a dangerous level within 10 years, potentially causing tens or hundreds of thousands of excess deaths annually. This transforms the hospital bed shortage from a current inconvenience into an imminent public health catastrophe. The article reveals we're already at 75% occupancy, up 11 points. I think as people hear this, and then they talk about the policy contradiction is also compelling. For decades, the U.S. deliberately limited hospital construction through certificate of needs laws to control costs based on the theory that once hospital beds are built, they tend to get filled regardless of need. Now we're facing the opposite problem, genuine need with insufficient capacity. I think everybody's seen this, right? We've all been in a hospital where there's beds in the hallway. I've been in one of those beds in the hallway. And it's because, and they will tell you, it's like we're waiting for a room to become available. And I think this is probably more acute where he's at in New York City than anywhere else, because it's so difficult to build a new hospital or to retrofit an existing hospital. It's hard to put more beds in. But my gosh, I mean, what's the solution to this? The converse is there's a lot of people saying, hey, we're going to make beds out of people's homes, and we're going to change the care dynamic where we're going to be able to deliver higher acuity levels in people's personal beds as opposed to having them come to a hospital bed.
When I thought about the article, I almost broke down the question in two. what is the solution and what are the implications? Because there are domains where the first-hand sort of solution might not be as practical, so the implications are going to be very different. And I think if you think about it conceptually, then there's only two ways to solve for that. Either you need to have less people going into the hospital,
or more beds.
Or you need more beds,
You need more clinicians for those beds as well. I mean, the problem doesn't just end; it just keeps going.
Yeah, which has all sort of the ripple effect sort of on the cost structure, which is an entire sort of separate conversation where everyone is currently in the boat of trying to say, how can we do more with less and actually sort of overcome some of these? And I think what hasn't been mentioned in the article, but what is, I think, one of the key themes that is happening in parallel, that you obviously have this massive shift sort of to ambulatory and sort of outpatient and different type of care settings that is all about sort of preventing people, or not preventing, or making sure that not everybody sort of ends up in the ED, because that's the most costly. And also the place where at the end of the day, ED boarding and kind of waiting for a bed becomes sort of the most imminent. The implication is there's going to be policy and strategy and technology sort of initiatives that are all focusing around, okay, how can we get more done with the existing footprint we have? And then I think there's sort of the long-term capital deployment around how do we increase the number of beds, and on the other hand side, move more patients to a different type of care setting.
And any initiatives that are addressing this? I mean, I saw Mayo has something in the Jacksonville area where they are doing higher level of acuity in people's homes and that kind of stuff, but it hasn't scaled. It's very limited in the amount of scale they've been able to do. Because when you think about that, you still have to get clinicians to those locations. And I mean, that becomes even more complex, the getting around the city to see just one patient, whereas when they're all on the same floor, it sort of works. I haven't seen a solution on this per se that looks like it's going to scale outside of the fact that we just need more rooms.
I haven't seen or heard anything that is extremely compelling. From where I sit, obviously, we are often getting called in when the problems are acute. ED boarding, what can we do? How can we use technology to sort of address some of these challenges? And you go further and you look at, okay, it's a discharge problem or it's an inpatient problem. So how can we improve inpatient flow so that we can actually reduce boarding? But to get to your point, putting a CIO hat on, I think the implication of these type of challenges sort of being brought into the room, now let's fix them as they are pure, I think is something that's going to grow and grow, given sort of the trends of where the, overall environment is heading.
By the way, this is very similar to other problems. This is the baby boom generation moving through the pipeline. They have been the massive bolus of things that have changed everything. But when you think about it, that baby boom generation went through schools, and we built 1 million schools. And then all of a sudden we had a whole bunch of schools that weren't filled. That same thing's going to happen here, because it has happened the baby boom generation just demographically ends up being a significant number that ends up shrinking. So you also don't want to make that over capacity mistake. But let's put on the technology hat, because the executive team calls the CIO in and says, what are we going to do about this? If I were the CIO, I think I'd break this down and say, all right, you tell me how you were thinking about solving this, and I'll tell you how technology can be applied. Because if you're thinking we need to build more hospital beds, then we need to free up capital in order to do that. So it becomes more of an efficiency play than necessarily a care play, where I go, all right, we can do this project and this project that will increase our efficiency. And if we do these things across the board, we're going to make our clinicians more effective. And if we do those things, we're going to create more capacity. Rather than saying, hey, here's a technology solution to this problem, I would say, how are you thinking about going about this? And then we can either help you to free up capital dollars to do it, free up clinician time to do it, or increase our capacity by being more effective with the capacity that we have.
Philipp, can I ask you a question? Because I think the problem of capacity and the problem of, at the end, call it patient flow, or like moving, a patient from admission to discharge, I think is probably the most complex operational problem to begin with. And I think calling it a problem in itself is misjudging it, because it's multiple problems. And it's one of those domains where there's not just one counterpart, right? Like it's not a security problem. So me as the CIO, I have my security counterpart. You're going to touch essentially all different aspects, from sort of the physician to nursing to operations. And so if you are being faced with, everyone acknowledges that there is this problem, but like, how do you now sort of break it down to even come up with, oh, this is a problem that we can solve with cameras. So this is a problem we solve with processor. This is a problem we solve with that new Epic module. Like, how to structure thinking around these multi-dimensional, multi-stakeholder problems from your perspective.
So when I look at those problems, I start with, Cotter's method, where essentially I have to build the burning platform. In order for me to build the burning platform, I have to create transparency into the problem, because people won't acknowledge that the problem actually exists or the severity of the problem, or they will say that problem's over there, it's not here. And so what I would look to do is to surface information about the flow of patients through our system. And I would try to measure time and where the sticking points are, what's going on, that kind of stuff. So you can elevate that to the conversation. When you create that transparency, now you can have real conversation, not based on anecdotes, but on data. And you're looking at it and you're going, all right, this is really what's happening within this hospital. And by the way, it's not the same in every hospital. There's different bottlenecks. This is what you're saying. It's complex based on a series of factors. So you almost need to come up with a methodology to, first of all, turn those anecdotes into real data, surface that real data, create a sense in which, hey, if we need more capacity, the capacity is right here in front of us. I've interviewed people, and I remember one of the stories that a patient had to wait 9 hours to be discharged because they were waiting for the specialist to see them. And I don't know if that's still happening today, but if it is still happening today, that's an easy fix. That specialist did not have to physically walk in that room. They could have come into that room the same way you and I are talking from New York City to Florida. I mean, they could have, from anywhere in the city, gone into that room, had the conversation with the patient and the nurse, and that patient could have been just discharged within an hour.
No, exactly. It's just more about having the right information at the right time in a lake of noise. I always say, like, to the team, look, at the end, patient flow capacity is a death by 1,000 paper cuts. It's not just one thing. It's the 100 little things that happen every day, everywhere. And my last sort of hospitalization experience with my son, which, all went well, but we were in the emergency department, waited 6 hours to get into an inpatient room. And the interesting thing, what happens is, if you're in this ED boarding situation, and I was there with my wife as well, so he probably every 20 minutes is asking, like pressing the nurse call button, asking. And so the amount of communication that gets created in the system, when are we here? When are we here? Right? Like, it's extremely inefficient. And then we are finally into the pediatric ward, and every single bed was free. I mean, there were like 3 beds occupied of like 6. And it was much more a transport issue than it was a capacity availability issue, while the ED was sort of overcrowded because it was not just for pediatric.
My wife was in one of our hospitals once, and the nurses did not recognize me, and they were complaining about the EHR. They were complaining about a couple other things while I was in the room. So, I mean, I have nothing to do. I'm just talking to my wife. I'm sitting there with my phone. So I text somebody from the help desk who's in charge of the help desk. I'm like, hey, there's a couple things going on, blah, blah, blah. All of a sudden, IT people start showing up all over the place. I was like, man, if only everybody had the ability to, like, with their phones, hey, this is what's happening, and mobilize resources. But I'll be honest with you. I mean, for me, if it's not uniformly understood, and there's not especially for these big operational changes that need to happen, I'm not going to be able to do that as the CIO. All I can do is I can shine a big spotlight on it and say, right there, this is what we're seeing. Then we could have real conversations with the operational team. It becomes an organizational change management project more than an IT project. How do you move organizations? And I find a lot of IT leaders don't know how to do that, how to mobilize the operation to change something. They know how to do the technology, take out their checkbook and buy a new thing, but they don't know how to mobilize the entire organization to an operational project.
I think in a lot of conversations we've been having, it's always, when we discuss sort of what are problems, what is the technology aspect, at one point there's a question of, so what's the ROI? Why are we doing this? And like, what are the hard cost savings? And I think the interesting thing is solving for this type of problem in light of the broader crisis, but also for the existing unit of analysis, which is the total beds that you have available today, which you're not going to change immediately. It is such a valuable problem to fix. And I think ahead of the call, if you can get one additional admission for every 50 beds you have on a weekly basis, I think it's roughly $500,000. Yeah. So you have like 10K per bed. And so if you look at all your different initiatives and you put in the ROI, there's really a lot there. If you just move the needle a little bit,
just move it a little bit.
That 9 hours, you discharge before 11, you clean that bed up.
I hear what you're saying, Philip. You're saying I'm a slacker as a CIO. I'm not helping. I get it.
No, I'm in your camp. Yeah.
I do want you to take you to the next article because it's indicative of a CIO's world, right? So connected health needs more provider collaboration for better data integration. This is a healthcare IT news story. Deloitte researchers say IoT technologies could make more agile health systems and better patient outcomes if challenges to more widespread adoption can be resolved. And the problem they're saying is essentially that device makers think lack of EHR interoperability is the main issue. They're missing the broader integration complexity that IT leaders actually face. The research suggests device companies misunderstand the severity of the challenges of moving the data back and forth. They're almost creating these little islands, and then the IT leadership has to deal with them. The complexity for IT, 92% of provider IT leaders say integrating connected devices into existing data systems is moderately to extremely complex. IT leaders cite multiple integration challenges, lack of interoperability, workflow integration, demonstrating end user value. It's not just about talking to the HR, it's about fitting into the entire existing workflow. I say that we go to this story next, and it's interesting because this could be the excuse that IT leaders could give you and say, look, Philip, man, I've got a lot of problems. I'm not just dealing with this one, I'm dealing with many. And this is one of those. And I guess my question to you, is this a device maker problem? Is this a EHR problem? Is this a government regulation problem? I mean, we keep creating these little islands of information.
I have a very strong opinion on this subject. Yes, so I'm going to call that out to begin with.
Okay.
And I'm saying this being a technology provider and CEO and entrepreneur. And so I know, what our type of people are guilty of. And so to answer your question, I think it's a device maker problem. And I also think it's a Deloitte problem because the article, I'm like, look at the headline. Yeah. IoT and connected care can transform outcomes. It's not speaking to value. It's speaking about this concept of technology and IoT as a whole. And that goes beyond healthcare, has suffered from being a technology looking for a problem. And if you go into the article, it says you as a technologist, right? Like, yeah, you get excited. It's like AI and the first ChatGPT version 3 years ago. Yeah, it's going to change everything. But now the question is where and what? And I think the article then says demonstrating end user value, is the number one reason adoption is slow. In other words, we have all these capabilities and now my IV pump can call the internet and do whatever. And we don't exactly understand how that is going to have a massive impact on your day-to-day workflow and the value it creates. So we give you the capability and we let you kind of figure it out. In other words, like if you look at a mature market, like the system integration job and figuring exactly out what the value proposition is up to me. And I feel, and again, I'm exaggerating, but to make the point, like you cannot be in healthcare approaching things from here's the technology looking for a problem and it's kind of 85% there and we let you figure out the 15%. I need to be able to walk into the doors and say, look, we are in the business of solving, ED boarding. We have done that for the following health system in those 3 ways. We've reduced boarding by like 30% here, 40% here. How did we do it? This. Let me take care of it.
Would you put cloud in the same sort of category?
All technologies suffer from that. And I think as part of the maturization sort of technology, you will see vendors and providers that either get that sort of right, or it never really happens to the full extent, that everybody has wished for. And IoT is still a little bit sort of in that bucket of great capability. We kind of understand we wanted a lot of data. Now what?
Here's what's interesting to me about that. By the way, I agree with you. It would be more interesting if I didn't agree with you because then we could argue. But there was this whole thing of blockchain is going to change healthcare and change the EHR. And that's the one that we all sort of laugh at because nothing materialized. There really was nothing there per se around it. And it really was a technology play. But then we move up and we say IoT, and everyone sort of shakes their head and goes, yeah, I agree with you. We don't just bring technology. Then we move up and we say cloud, and people go, well, wait a minute. I mean, cloud really is changing things, blah, blah, blah. Then we move up and say AI, and people are like, well, no, AI is going to change things. I'm like, we're making the same mistake on all four.
It's the exact same thing. And I think to some of your like excellent sort of LinkedIn articles you're publishing, like you can replace the word and just change the date back 2 years ago, 3 years ago, 5 years ago. It's the same thing. Like I think there's a lot of AI governance conversations right now, right? Like at the roundtables, etc. And if you delete the word AI, you put in a different word, cloud, IoT. I think with one of the last roundtables, somebody said, yeah, it's kind of the exact same conversation we've been having, right? Like 3 years ago, 5 years ago, it hasn't really changed. And look, again, like, why am I making these statements sort of around the IoT? If you were to ask Goldman, like one of our investors, about Contact.io, and we have these like polished banker presentations, they would probably put us into the IoT category because we provide devices, location services. You go on my website, do we speak IoT? Like, is that sort of, no, I'm trying to have value-based conversations around specific problems that we've solved before. And so it's a paraphrasing. And that is why I think Deloitte is part of the problem, because if you create these type of headlines, you're approaching things from the wrong perspective.
Deloitte is part of the problem. I love that.
By the way, they're great. Yeah, I'm just like
they are great. Let's go to the last story. We're already over time, but we'll do it anyway. I think it's an important.
You'll cut it short at the end.
Oh no, I won't. This is fun. So AHA reports fines workplace and community violence cost hospitals more than $18 billion annually. So AHA did a study June 2nd, 2025, revealing that hospitals spent $18.27 billion in 23.
And Bill, by the way, like just as a heads up, they've done this study before in 2023, and back then the number was 2.7 billion.
I was going to actually, I have some of the other studies done.
Exactly. It went up significantly, and that's like 20 million for a 1,000-bed hospital.
There's a confluence of things here. One is, I would like to focus on actual hospital violence against nurses and doctors. That's something I can have an impact on. I think they're pulling in like everything related to gun violence and that kind of stuff. It's like, so they're saying, hey, any gun violence victims in these cities that come in, their thesis is if there wasn't a gun, those people wouldn't get hurt. They wouldn't be coming to the hospital. I think, again, I'd have to read it more closely, but the lower number, the billion to 3 billion number, I think is actual violence against doctors and nurses in the ED and other things, which is also a serious issue. And one, I think we have a role from a technology standpoint of helping to support and helping to avoid, if possible, either with cameras in the room, badges, screening, all sorts of things to potentially protect our workforce. You're like reading the article now to find out, aren't you?
Part of my prep notes, like this is where I have like one stat after the other. And I mean, we are, as a platform play, we're in the business of addressing some of these issues. But like, I think the things that are standing out to me is violent incidents between 2019, so just pre-COVID, like 2022, 112% spike against nurses. So like double, right? And then talking about, again, the emergency department, it says 100% experience verbally abuse annually and 50% physical assault. And I don't know, have you watched The Pit?
I've not.
You should give it I actually think it's a great show, and it's about the ED in the Pittsburgh-based hospital, and like workplace violence is sort of omnipresent there. And I think the issue I'm seeing, and I'm like, I think if you look at what health systems are currently doing, I think there's a lot of things around, let's put in metal detectors. If we don't have that, we could call this a technology response or not, but it's like sort of, I think I haven't been to a hospital, at least in a major city, where I haven't seen sort of metal detectors. And then there's a whole bunch of different things sort of around process and technologies. And you mentioned camera, but here's the thing I think that we need to get right. You need to think about process and technology through the lens of preventing a situation from escalating, because the environment is going to be the environment. Yeah, there's going to be people, they're very vulnerable, they're stressed, etc. The waiting in the ED. So I think the concept around sort of de-escalation and trying to intervene earlier is critical in getting these numbers down. And so when you think, for example, about a camera can, through AI, automatically detect if there is sort of physical abuse happening, but then it's sort of too late. Then it's about, okay, damage construction. Obviously, speaking a bit selfishly, like having a portable duress button that you equip as sort of a caregiver with, which we currently see being rolled out in every large health system in the US, predominantly has the ability to call for help when, you know, the other party is maybe not even acknowledging that this is currently happening. And because of that, you have the capabilities of de-escalating and getting response in the precise location before something happens. Yeah.
Right.
And there's a lot of thinking that I think needs to go into it, but I think it absolutely needs to change, because otherwise the entire kind of workforce shortage, the Gen Z, the Gen Y, they getting out of the workforce. You have one of these events and then they will say, yeah, great, I'll do something else.
Let me ask you this. When you're in an airport, do you think you're on a camera at all times?
No, but I know I am. But I don't care.
But you don't care because you'll trade that for safety and making sure that when you get on that plane, you're safe. I think that's where we're going with hospitals. I don't think there's going to be anywhere in a hospital except for a bathroom where you are not on a camera at all times. And I think our security measures will continue to get more sophisticated as we move along, be able to potentially compare facial images to criminal databases and that kind of stuff. I don't know, maybe this is me watching too many Netflix shows and that kind of stuff, but they make it seem like that's really easy to do, like the image, and then it goes against the database and says, hey, this is a dangerous person and that kind of stuff. But I think we're going to get to a point where everything that goes on in a hospital, from the ED to the OR to patient rooms and whatnot, is going to be on a camera. And you're right, it is reactive.
Those things are not mutually exclusive, right? I think at the end of the day, there's a whole bunch of things that need to happen to combat and address that. But I feel, I mean, it all starts sort of with the awareness. And I think that's something that has certainly shifted from even 2 or 3 years ago.
Philip, I just want to point out that all three of these things we talked about are going to require money. They're going to require effort and resources. They're going to require operational support. This is why it is such a complex thing. And we're only touching on 3 macro trends that are going on in the industry. And we know there's like 100 macro trends that are going on in the industry.
Yeah. So what's your advice?
Keep doing what you're doing. I mean,
no, not to me. I mean, to the audience. I mean, I have to run a company, but not, you know, a health system.
Again, now is the time for health system leaders to be so focused, laser focused on a strategy that is going to deliver on their core priorities. I can't tell them what their core priorities are because Northwell's priorities are different than Northeast Georgia's priorities, right? But they need to be laser focused on those things. They need to be adept at saying yes to the right things, but they need to be even more adept at saying no to some really good things, but saying no, like we don't have the resources. We have to focus on these things. It is a constant barrage of requests for money, for resources, for new technology. And it's got to be laser focused on delivering outcomes. And I think we're getting there because we've been in this crisis mode now pretty much since the pandemic.
I agree. And I think, I mean, at the end of the day, I think we have to now also observe sort of how is the funding environment going to sort of further evolve. But yeah, we'll have to make cuts in some domains in order to continue to invest in different domains. And it's almost like I sometimes call it the Microsoft problem, right? Like they announced we're laying off 3% and we're creating 10,000 jobs here. Like these messages typically come in sort of at the same time. So it's really about, you know, transforming and shifting where to focus.
Biomed was the bane of my existence. It's like you have all these devices, some of which are like 20 years old. They're running Windows XP, for heaven's sake. And it's like, well, we're going to continue to use these, so figure out a way to secure them. And the answer to that is, yeah, we can-ish. But at the end of the day, they shouldn't be in here. Like we should get rid of them. There's this whole concept in IT that gets lost, which is when you buy something, put a date.
You need to maintain it.
Yeah, well, put a date on it when it goes out the door. Like, don't assume that a technology has a 20-year life cycle when it only has a 10-year life cycle or a 5-year life cycle. Put a date on it. It's going out the door on this date. We will need to
Yeah.
reallocate budget on this date for new stuff.
And you know who has done an excellent job on this?
Who's that?
These guys, Apple. Like, what's the life cycle of this phone? Anybody, maybe a year, 2 or 3. Nobody would say 5. And who has done an excellent job in the enterprise? Cisco. Think of your Wi-Fi refresh cycle. What's the average Wi-Fi refresh cycle that's recommended? 5 to 7 years.
Yeah.
Great. I mean, you go into a German hospital, you'll see sort of Siemens routers from like 1995 on the wall. It's a different problem, but like the conception, right? Like that you're saying is like, okay, I mean, IT leadership, but then every 5 years, there's a new generation, Wi-Fi 5, 6, 7.
It's just a perpetual, it's maintenance in some cases, and then it's replacement in others. It's just a perpetual.
And it's cost. And it's another.
Well, and like if we've decided that Wi-Fi is important to have in every one of our hospitals, then what we're saying is it's like plumbing. We've decided that this is as important as our plumbing. The difference is that in 5 years, there's going to be much better Wi-Fi, whereas plumbing is plumbing. It has a life cycle of forever in that building.
Yeah.
In some cases, I've had plumbing problems. Anyway, Phil,
Good.
We'll end on that. Hey, I love these conversations. Thank you, and appreciate the time.
Thank you, Bill. Always fun.
Thanks for listening to Newsday. There's a lot happening in our industry, and while Newsday covers interesting stuff, another way to stay informed is by subscribing to our daily insights email, which delivers expertly curated health IT news straight to your inbox. Sign up at thisweekhealth.com/news. Thanks for listening. That's all for now.